Hey there, my name is Andrew Schmidt. I'm an assistant clinical professor in the emergency department at UF Health Jacksonville, and this presentation is going to be on the approach to the pre-hospital difficult airway. I need to start by giving credit to the book where most of this information is from, and that's Emergency Airway Management with Ron Walls as the editor. Three of people I look up to in medicine, Doctors Godwin, Luton, and Caro, seen here, who all work at UF Health Jacksonville, are all authors within this book. If you're at all involved in emergency medicine in the hospital or pre-hospital setting, this is definitely a book that you need to have on your shelf. So why do we need to talk about this? Well, in the hospital we have lots of resources, lots of people around to help out. We do have difficult airways all the time, but you may have a little more time, or at least a little more room to work with the difficult airway. This contrasts with the pre-hospital setting, where time is not on your side, resources may not be on your side. You need to make some quick decisions and decide whether or not you need to intubate someone, and if you're going to, how best to approach it. Now we've made the decision to intubate someone. I want you to think of the approach to the airway as a continuum of steps, from normal to difficult to failed airway, and then unfortunately death. The whole point of this lecture is to give you an algorithmic approach to the airway so that you can recognize the difficult airway and hopefully avoid the failed airway and eventual death. So why do we intubate someone? Well, in this approach there are four main reasons. First off, airway protection. So due to trauma or disease you feel like this patient can't protect their airway. Next is failure of ventilation. So the person isn't having proper gas exchange for various reasons. Also there's failure to oxygenate, so you're not able to keep the patient's oxygen levels to a level compatible with life. And last is impending clinical course. So you just kind of look at this patient and you say, look, due to their disease or injury, I feel like this airway is going to get worse before we get to advanced care. So here's the basic algorithm for pre-hospital difficult airway. We're going to go through this in a stepwise approach. First off, we need to recognize a difficult airway and be able to predict it. To do this, you can ask yourself four basic questions. Is he easy to intubate? If I can't intubate him, can I bag him? If I can't bag him, do I think I can place an extraglottic or supraglottic device? And if all else fails, do I think I can crike him? To put this in a more formal way, is it difficult laryngoscopy, difficult BVM, difficult EGD, or difficult crike? To help make it easier to go through each of these steps, the authors of Emergency Airway Management came up with four acronyms to assist in evaluation of the airway. The first acronym is LEMON. I like to add an S for the pre-hospital environment, and we'll talk about that in a second. We'll go through each of these steps right now. The L is for look externally, and this is what's called your clinical gestalt. So you walk up to the patient, you look at their injuries, you look at their illness, just look at their condition in general, and do you get a feel that this may be a difficult airway? The E is for evaluate 332. 332 is some steps you can take to measure distances on the patient's anatomy. And if these distances all are correct, then you have kind of the ideal visualization of the patient's airway. Anything outside these ranges may mean a more difficult airway. The first three is for can the patient fit 3 of their fingers inside their own mouth. The second 3 is the distance from the chin to the hyoid. And the 2 is for the distance of the hyoid to the thyroid cartilage. This may be a little more difficult to do in the field, but if you kind of just take a quick look at the patient's anatomy and see if it's within these ranges, you'll be able to tell if it may be a difficult airway or not. Now when you look at a side view and you shorten the distance from the chin to the hyoid bone, as you may see in patients with Treacher-Collins syndrome, you see that there's less room to displace the tongue, which is one of the roles of the laryngoscope, so you may not get a great view of the cords. Now if we shorten the distance from the hyoid bone to the thyroid cartilage, we get what people describe as an anterior airway. The airway is not actually more anterior, it's actually more proximal, tucked up behind the tongue. So again, you aren't able to see the cords as easily. Now the Mallampati score is actually developed for use in the OR, and it's definitely difficult to do in the field. But the idea is that you have the patient sit forward, open their mouth as wide as they can, stick out their tongue. And the score ranges from 1 to 4 based on how much of the anatomy you can see. Again, kind of difficult to do in the field, but you can tell a big difference between the Mallampati 1 where you can see all the oral structures and the Mallampati 4 where essentially you can only see the hard palate. Obviously, as the Mallampati score goes up, the difficulty of intubation goes up as well. Now, the O stands for obstruction and obesity. The patient could have dentures in the airway, they could have an expanding hematoma, or bleeding from the nasal passage, or as you can see in this picture here, a knife sticking in their neck. So obviously if they have any obstruction in the airway, you're going to predict a difficult airway. And N is for neck mobility. You may see decreased neck mobility in our elderly patients with severe kyphosis or in a trauma patient with a C-collar. When these things are in place, you may not be able to mobilize the neck like you like to be able to visualize the airway structures. And finally, S is for space. I like to add this in for the pre-hospital environment because obviously it's unique. You may be laying on your stomach, you may be in the back of a truck or a helicopter, you may be in the passenger cabin of a car, but you're not working with the kind of space that we're used to in the hospital. The next acronym is MOANS. This is a system that you can go through to figure out if the patient may be difficult to utilize a bag valve mask on. This can be very important if you're planning on pre-oxygenating the patient or if you have a failed airway and you're trying to figure out if the patient is going to be able to be salvaged by a bag valve mask. The M stands for mask seal. So any severe trauma to the facial structures or any patient with a large beard, it may be hard to get a good mask seal on them. If anyone has done bag valve mask ventilations before, you know that the absolute most important part is getting a good mask seal. O is for obesity. These patients are more prone to obstructive sleep apnea and having airway structures fall in the back of their throat and obstruct their airway. A is for age. Elderly people have decreased airway muscle tone, so if you paralyze them or if they're just unconscious and weak, they won't be able to hold their airway structures open as well. N is for no teeth. If someone doesn't have teeth in, they don't have the right support structures that the mask portion of the BVM is designed for. That's why in the hospital, if someone has dentures, we like to keep them in while we bag them because those underlying support structures stay in place. And finally, S is for stiff lungs. On the left, we have a very classic COPD patient. So they have very stiff lungs from their chronic disease. On the right, we have, which JVD is what that's showing, and that's for our CHF patients, so patients with lots of fluid in their lungs, may be harder to bag. The next mnemonic helps you determine those patients who may experience difficult extraglottic device placement. The R is for restricted mouth opening, which may be due to their natural anatomy or an injury or C-collar placement. O is for obesity or obstruction. Obese patients in general have higher airway pressures, which may actually overcome the leak pressure of extraglottic devices. D is for disrupted or distorted airway, which may be due to injury. And S is for stiff lungs, which once again will cause increased lung pressures. Our final mnemonic helps you determine those patients which may be a difficult crike. The S stands for surgery, so any history of surgery like a previous crike or thyroidectomy, which may cause scar tissue to form in the area. M is for mass, whether it's malignant or any type of expanding hematoma. A is for axis or anatomy, so any obese patients may not have good access to their neck. R is for radiation, which will also cause scar tissue in the area. And T is for any tumor in the area. Now once we've evaluated a patient for a difficult airway, our next decision we need to make is whether or not we need to scoop and run. Now there are a million reasons to scoop and run a patient, some better than others. And this is a pretty hot topic in pre-hospital medicine right now. But I want to try to give you some evidence to help guide your decision making. The truth is, the majority of pre-hospital providers probably don't get the number of attempts needed to really become proficient in emergency intubation. In addition, there are a number of different factors playing against you in the field. When we look at literature just from the past year, there are 3 major studies all showing better outcomes when patients are treated with basic airway maneuvers, including bag valve mask, instead of taking the time and effort to intubate. And while this is a debate that can go on for days and days, it's just important to keep this in your mind depending on your location in relation to the hospital and the patient's condition. Now after this consideration, if we decide to stay in play, we need to figure out if the patient's current condition forces us to act at this moment. If you are forced to act, at this point you need to give RSI medications based on your local protocols, give one best attempt, and if successful, initiate post-intubation management. If this attempt is not successful, we go into what we call the failed airway algorithm. This algorithm has 2 different categories. The first is cannot intubate but can oxygenate. These people you scoop and run and treat with bag valve mask. And the second is the cannot intubate, cannot oxygenate. These you may attempt extraglottic device placement while setting up for a crike and then move forward with cricothyroidotomy. This is where your initial evaluation of the difficult airway comes in handy. If you're able to determine up front that this person is going to be a difficult crike, you may move towards scoop and run and bag valve mask earlier on in your treatment. Now, if you move through your algorithm and you're not forced to act and all other factors are kind of ideal, you move toward RSI with a double setup. Now, this would be something to be comfortable with and familiar with if you're in a location far from the hospital. But if you practice fairly close to a hospital in an urban setting, I would actually recommend moving from the bag valve mask or extragalactic device and going straight to the hospital. Knowing what we know about intubation and outcome, I think it's best to get into a controlled environment with advanced medical equipment. Alright, now we're going to move on to one last thing. That's the decompensating intubated patient. So you evaluated the patient, you went through your algorithms, you set up your setup perfectly, you got your equipment working right, you intubated the patient, you high-fived your buddy, and now they're decompensating and you don't know why. Here is a quick method to go through to determine exactly why this is happening. For this we have one more mnemonic, which is known as DOPES. D is for checking if the tube has become dislodged. This could either happen initially during the intubation by passing the tube too far down into the airway, or if the patient's neck is extended or flexed during transport, especially in the pediatric patient. O is for obstruction. Patients who are bleeding the airway or have a lot of mucus in the airway, you may need to pass a suction catheter, and the tube can also become kinked, especially where it passes into the mouth. P is for pneumothorax, so checking both lung fields, making sure you're still getting adequate lung expansion. The treatment for this is a needle thoracostomy. E is for equipment. For all you know, your vent may not be working. The best thing to do is disconnect from the vent, put on a bag valve mask, and bag them with 100% oxygen and see if the O2 sat comes back up. Also, check the oxygen supply. It wouldn't be the first time the oxygen ran out on a truck. And S is for something called breath stacking. This is especially common in asthmatics. Asthma is an obstructive disease and they actually trap air in the alveoli. If you think this is happening, if you feel like the patient isn't exhaling fully, you disconnect them from the vent and allow them to naturally exhale. Alright, well that's it. I have three major things I want to go over that I want you to take away from this talk. First, always have a controlled algorithmic approach to the airway so that you don't miss something and that you don't get yourself in trouble. Secondly, have a plan A, plan B, and plan C, and don't be afraid to change things up depending on the environment. And third, don't forget the power of bag valve masks and extragalactic devices. Intubation is sexy and it's fun to do, but sometimes the more basic the better.